Hear me? Yep. So again, well, first of all, that's very impressive turnout for a Saturday morning. Quite impressed. Well, first of all, thanks to the organisers for inviting me along. I'm David. I'm a pain specialist. This is a bit of a win-win situation, isn't it? So it's not only a good opportunity for us all to find about each other and learn from each other, but it's also CBD, isn't it? And the best thing is it gets me out of netball. I've been asked to basically do a chat about pain. It's a huge subject. You could spend forever talking a lot about it. I've decided, I mean, my past life is, I've had a few different areas of medicine that I practiced in, and it wasn't really until doing pain that I realized how badly pain is taught. So I've kind of gone for a sort of more kind of blanket approach to trying to talk a little bit about everything at the risk of not going into too much depth. So apologies if it does feel a little bit like being a medical student, and hopefully you'll get something out of this. But again, I think just having a bit of a framework and an approach is probably better than going into some fine minutiae. I'm on Zoom incidentally, so hello everyone. So this is working. So I work as part of the Neurospine team. It hasn't shown all of the people actually in the team here. So there's a couple of neurosurgeons, there's a couple of spinal surgeons, there's myself, we've got a physician on board as well. There's a big physio team as well that don't feature on this, an excellent admin team. There's a managing director hiding in the corner. And there's also, I think, an occupational therapist. And there's, well, so there, I think I've probably missed some few, but it's expanding. So this isn't a true reflection of everyone that's there. Now, to try and make it more relevant, because again, I think once you start becoming a specialist, you just look at your little area and you get excited about things that aren't relevant. So I always ask for a bit in advance of what do you want to know about, what's helpful, and as ever, GPs always give a quite normal, real-world approach to everything, and they've asked for a pain management algorithm, which is fair enough. So who to refer when, a realistic approach, supplements, involving the MMTT, and as ever, opioids always comes up. Any one of those areas, you could talk for 40 minutes. So I'll just, again, try and go over everything. How I've translated that into what I would think we should talk about is, okay, let's try to talk about a pain management algorithm. Algorithms are kind of all right, but again, I would just heavily emphasize everything's got to be individualized, you know, so it's a bit of a framework. I'll talk about that and this is the kind of medical student bit, I'm sorry, so the history, exam, investigations, and a bit of generalized treatment. With regards to specific treatments, I'll talk about that a bit later on when I talk about the specific pain types, as you can see in red down below. And then we'll talk a bit about opioids, why they're so bad. The prescribing code is probably relevant, and then talk about the pains. And if you've got time, we'll talk about cannabis and the rest of it. I see a few people taking photographs. Incidentally, look, feel free, obviously, but I'm more than happy to share slides and email them through for your information. So don't feel the need to take photos of everything. Just listen. So getting on with it. So I was asked to submit questions for CBD as well. I don't know if this has happened or if it's going to happen, but these were my questions anyway. What are the 3 types of pain? Well, if you have to do this kind of there in red. A useful guide for the pharmacological management of neuropathic pain. Just make Is this thing up here?
Yeah, it's
cool. I think I kind of mentioned that here as well. This thing here, the white type lines. So you're getting cheats. And then the bit here that I always get asked is about the Penstol's prescribing and how that relates to the prescribing code and, you know, scary emails and phone calls from the Department of Health. So anyway, moving on. So this is the medical student bit. So part of the assessment, again, at the end of the day, it's pain. It's not just pain. It's an individual assessment. It's trying to get to a pain diagnosis. Again, I always just used to ask people how much pain and where is it? What's the pain score? That's a bit kind of superficial. It is just to start the end in sight, trying to figure out where's it coming from, what's the underlying etiology. It's not always transparent, it's not always straightforward, and it's sometimes an evolving plan. I don't need to tell you guys, I'm sure the most useful information is what comes out of the patient's mouth. You know, what was happening at the time, you know, is it episodic, is it evolving, you know, what were you doing? The kind of what was happening in the time of your life is kind of more related to widespread pain, headaches. There's often a kind of psychological trigger or something. Again, where is it? The descriptors are important. We'll talk about that a bit later. But if they just say it's really bad, it's severe, that's you know, look sympathetically upon them, but then, you know, try and probe for a bit of a deeper character. What does it exactly feel like? Tell me without using the word pain. what makes it better and what makes it worse, and then what's helped in the past. Again, I've often people turn up, they've had injections, they've done a physio that just made everything worse, they've tried 101 medications. It's actually really useful to try and work out what has happened, and if they've been on 20 different drugs, that doesn't help. You just got to try and piece it apart. And again, we'll talk about that a bit more, talking about the specific pain types, but past treatments are really important. Will this work? Yes. So this is, so as part of your assessment, obviously looking for red flags. So this is a bit of a kind of advertising thing for our own company. So obviously we run an acute disc disorder priority. If there's some severe, radiculopathy, something that's worrying you, there is an acute disc service. So basically, you just have to fulfill the criteria there. Acute severe pain in the distribution of a nerve with some sort of CT evidence or MRI after the sort of some impingement or something, and they will generally get seen within 3 business days. Assessment. Now, this is the app that I've got the luxury of being able to spend 45 minutes with my first patient. So, you guys don't have that. I appreciate that, but I've got this little app. This is all from the app. This Essential Anatomy 5 is pretty cheap, but it's just really handy. Like, patients really appreciate it. They don't understand, anatomy, and why would they? But it's really handy because you can basically add on skin, take a look at bones, add on nerves, vessels, and you can actually get a figure of where things are coming from. It was very apparent when I was teaching RMOs and medical students that back anatomy, everyone thinks everything is in actual fact a lot higher than you expect. And basically these are all perfectly lined up. You see this? So that's, that's the top of the lower back is here. So everyone usually points to this bit here and says I've got lower back pain, whereas usually it's exactly that joint region. So again, I'll show this picture when I talk about back pain a bit later, but again, everything is just higher up. And if you get the app, have a bit of a play, spend time pushing fingers and trying to work out where it's coming from. As part of the assessment as well, again, God, you guys have got so much to know about every subspecialty. And if you like me, neurology, just, dermatomes and myotomes goes in one ear and out the other. This is the American Associations for Spinal Injuries kind of infographic. If you basically just Google Asia PDF, the first thing that comes up is the Asia website. They've got, this is the simple thing. I stick it on a tab on your internet browser, and you can basically just match up myotomes and then to dermatomes, and these are the key sensory points, which again you can do it and send, and then you basically just try and marry that up to, is it a radiculopathy, is it in keeping with an L5 and S1, etc. And you can look at all the myotomes without having to guess and think back to what you learned years ago. Investigations. I think one of the questions was what investigations do I want before a referral? Not really that much. I'm more interested in the history. Like a decent history. There's 2 or 3 lines of severe back pain started after this, and then it's referring down the leg, and I will triage and request MRIs at the point of triage. And if I request it, it's free. I don't know what your relationships are with radiology places, but it's free for the patient if I request it. I sent an email actually to a big practice saying, don't waste the patient's money. I'm more happy to request it. I think I got a reply since they're a bit offended because I was kind of trying to, dumb down their approach. That's fine. But it's just if patients are struggling financially, they get it free if I request it. So basically, for spinal imaging, for spinal pain, it's divvied up into structure, a bit, static, dynamic, and a bit more functional. CTs are fine, but they don't really show, soft tissues very well. Everyone gets caught out occasionally with underestimation and overestimation. And the underestimations can be quite significant sometimes. The MRI is best for, I've had a few whereby there's looks pretty normal, and then actually they've got critical, canal stenosis, and then I onward to the referral, obviously, to the surgeons if deemed necessary. So that's the static. The structural stuff, so this picture here, actually, you can see there is a bit of anterior prosthesis at the L5-S1 junction. I tend to ask flexion extension views. It's just helpful to see if there's any dynamic instability. It doesn't often change management, in all honesty. It's only if it's dynamically unstable and then causing severe radicular pain of the nerves that it pinches, then it's more relevant for sort of surgical options. The biological activity, this is more functional. The biological activity, this single positron emission CT, SPECT CT. There is an expense to the patient, unfortunately, even if I request, I think it's about just sub $300, but it's a one snapshot in time. It basically, they get injected with technetium, which goes around and then gets taken up by active tissues. And then the graphical representation is what they get, it kind of shows up as hotspots, which often change, it does change management from an interventional point of view. For example, this person, they've got angiolysthesis here. So you think, well, this is maybe moving backwards and forwards. They've probably got a bit of active disc uptake. You can see the disc it's fine. It's the disc below it that's happy and facet joints at that level with the angiolysthesis. So it does help direct interventions. Whatever you do, again, patients, I think I talk a bit later on about language, but be careful if you do request these, don't show it to the patient. It's really hard to unsee those red dots once you've seen them, and our language is very important. Like scans don't show pain, and these things are common findings in asymptomatic people as well. And if you show a patient that's already wound up, anxious, very, hypervigilant, catastrophizing, if they see red dots everywhere, they'll just lie in bed for the rest of their life. So just be careful. We're on the investigation side as well. So that one was all the sort of spinal radicular pain, radiological investigations for sort of neuropathic sort of pain, widespread pain. Thank you. I often get referrals through with sheets and sheets and sheets of investigations. Probably, and you're probably damned if you do or damned if you don't, because it doesn't change an awful lot. If there's a neuropathic pain element and we think it's secondary to a systemic disease, of course, these are the multiple etiologies of a peripheral neuropathy. You've got to do your due diligence and ask for blood tests. And I kind of ask yourselves to do that, and we'll request them and ask you to manage any underlying disease. But I'm not going to manage the underlying disease. If I think there's specifically in young people, if you think there's an underlying rheumatological condition going on, I have a low threshold for referring for a rheumatological opinion. And if I get sent tests with an autoimmunity screen, that's what rheumatologists do. They interpret that. I would just be doing the patient a disservice to try and do that. Nerve conduction studies, again, that's often quite helpful to work out if it's a peripheral neuropathy or if it's a radiculopathy, because often things coexist. Now, before I talk about the general, moving on, the general sort of treatment of kind of pain conditions, it's probably worthwhile just going a little sniff of neuroscience just to give a bit more background to sort of frame it better. So the point of our nociceptive system is an alarm system to tell us about potential tissue damage and make us lie down and heal. It's a survival advantage. So we've always got, nociceptors that are kind of setting off messages, trying to go up to our brain and tell us about bad things. But there's a balance. So this is the bottom up and top down thing. So we have constantly active, tonically active, descending inhibition of pain. So there's a large part of our brainstem and our para-aqueductal gray that sends down individual fibers to every single segment. Every single segment of the spinal cord, just to dampen down and turn off pain signals. There is a balance, and some people have better, and it's termed descending noctus inhibitory control, so DNIC. Some people have better systems than others. Even if you've got a great system, it's very easy to wipe that out. And it's simple things. And this is where it comes on to, like, the biggest bang for your buck is often the simple things, not surgery, not interventions, not drugs. So things that knock it out. People that are sleep deprived, it's gone. It's absolutely gone. Everyone knows if you've had a couple of nights bad sleep, everything hurts. You're all a bit achy and sore. There's nothing wrong with your body. It's just your descending control gone. Psychological state, again, that's a huge thing. People that catastrophize, you're basically, again, it's a survival advantage. If you're primed thinking there's some threat going to happen somewhere, you turn off this so that you're amplifying your peripheral intake of bad signals. So again, mood state, basically, catastrophizing, hypervigilance, anxiety, all these sorts of things can wipe out a lot of drugs as well. Again, non-prescribed bad drugs that everyone chemically copes with can knock it out. So the bad thing is that that's the pain signals kind of going up to our brain. Once it gets into our brain, well, then all the reasons why you potentially knocked out your DNIC then aggravate it once it's in your brain as well, because we have a somatosensory cortex that's discriminatory of where certain issue is, but that doesn't, the superimposed suffering and pain experiences because of all these 26 bits of our brain that bounce around back and forth. So, the PTSD people, very anxious, they've got a massive amygdala. So that's not only they're getting signals that probably shouldn't get to the brain, once it's in their brain, it's then even worse. So it's trying to, and no drug, 26 areas of your brain, what one drug is going to fix that? It's the human body is just far too complex. So this is where the kind of simple things, which is thinking about sleep, I'll talk about later, but doing the simple stuff. Treatments, so physical therapy. Most people, as long as you have some sort of guidance on their physical therapy, they get better. Again, we'll talk about expectations a bit later as well, but I put this sort of article up just to sort of say that there is this phenomenon of exercise-induced hypoalgesia. It is a bit variable from one person to another. There is occasionally people that it just doesn't really work. Again, a good physio will see that, and actually exercising the non-painful bit of the body can then reactivate that and actually help them. But again, the biggest thing is having a good relationship with the physiotherapist. Now, that commonly people will turn up and say, I tried physio, it was no good, it just made me worse, so I stopped it. It's what type of physiotherapy? Again, it's active versus passive, dry needling, massage, 5 free treatments just doesn't do anything. It's trying to actually get them moving, reactivating muscle, rehabilitation, that kind of stuff. And if try to get, we've got physiotherapists. There's a bunch of excellent people in town. There's Body Logic, there's Pain Options, they're all excellent, and it's hands-off. Patients expect hands-on therapy, but that doesn't do anything. It makes you feel great for a day or two, but it doesn't do anything long-term. But try and harbor relationships with your local physios and talk to them and find out what they do and, communicate. Yeah, the threat value, I'd say, again, for patients that there's nothing much wrong with them, but they're just a walking board because they've seen a red dot on a scan, they're petrified that something terrible is going to happen to them. Is the ones that are really hard, and you've got to give them that movement confidence. Lifestyle, again, I think there's someone talking about functional gastrointestinal disorders, so I'm not going to say much about that, but everyone knows about the gut-brain axis and their effect on mood. The gut's a huge serotonin organ of our body, serotonin producing organ of our body, which affects mood. We all know that. A lot of people with IBS mostly have an underlying anxiety state, which kind of goes backwards and forth. There's this whole microbiome thing. We get that when we're a child. You kind of inherit from your mother, but then bad drugs, antibiotics, stress, and all the rest of it can actually result in a bad microbiome. Hence, thinking of better diet, well-balanced diets. Actually testing someone's stool sample. The leaky gut phenomenon, which is basically a bad microbiome. You can just have stuff leaching into your body to create a chronic sort of inflammatory state. It's a well-balanced diet. Okay, so avoiding lots of meat, avoiding lots of sugar. Sugar produces insulin, which is very pro-nociceptive. This obesity and meta-inflammation is a massive area. Excess adipose tissue just leaches out inflammatory cytokines. We've all had a virus, or that's basically cytokines released all around our body, causing inflammation of our glia, which is part of our nervous system. Constant inflammation does the same. There's quite a few people that have picked up actually widespread pain that have actually had subclinical celiac disease, and they've changed the diet and they've actually got better. Smoking, alcohol, smoking, they're both acutely analgesic, but chronically, so the nicotine is analgesic, constant exposure. Monkeys around with our nicotinic pathways exacerbates it, as well as all the toxins that are neurotoxic. Alcohol, again, acutely analgesic, but the metabolites are neurotoxic. Sleep hygiene, honestly, if you can just get people sleeping better and moving better, you can make a huge difference. Again, the DNIC stuff that I've talked about already, things like, the OSA, PTSD sort of connection, it's huge. You're releasing adrenaline all the time, and have your amygdala swells to the size of a watermelon, and it just amplifies the pain experience with your own head. Caffeine excess, everyone does that. Basically, tell patients to Google the term sleep hygiene and address anything that's affecting them. Benzodiazepines do not create restorative sleep. What you're doing is creating chronic sleep deprivation. Effectively, you're just tranquilizing them. So it's an easy thing to go down the route of, but it's a bad idea. On to general treatment against supplements. I'm not going to go. I've actually created a bit of a handout which I'll email. But the supplements, PA probably is the thing that comes up a lot. Again, these are just 2 articles that I found. It's quite complex the way it works. It's a food stuff. It's not a drug. It's just a fatty acid that comes from our diet in concentrated high form. It can help with neuropathic as well as nociceptive inflammatory pain. Everything's a trial. Like some people get huge, like a lot of rheumatoid arthritis patients see huge benefits from this stuff. So again, it's worth a trial. I think it costs about $1 a day. The more you buy from a pharmacy, the cheaper it gets. And I've got a handout all these other things for supplements, but I don't want to waste too much time because everything's worth a trial, and I'll put a bit of information in that, but again, I can email it through to everyone. Psychological stuff, I think I've kind of hinted at that as well, massively important. So the pain and mood disturbances feed off each other. One creates the other. Psychiatrists tell me to sort out their pain and they'll sort out the psychiatry and vice versa. They coexist, they're equally important. What happens with the mood disturbances? Mood disturbances as well as that also results in this, the maladaptive cognitions. They start, catastrophizing and hypervigilant, and then that stops them moving. So what you're trying to do is make sure your language doesn't make it worse by just sort of reassuring them that it's normal. There's nothing much to worry about. You've just got age-related changes, and then any psychological intervention. Again, it's part of motivational interviewing, isn't it? it's right. It's only useful if the patient believes in it and understands why they're doing it and actually wants to engage. So there's no point just sending someone to a psychologist because they're being told to. It's hard work to actually get meaningful impact with the psychology. Is that sometimes they have to go on mood stabilizers in order to help their mood disturbance, which then allows engagement in clinical psychology to deal with the reasons for their mood disturbance and then maladaptive behaviors and conditions. The apps, mindfulness, awesome. They're cheap. I don't think there's any side effects to mindfulness. It's just trying to get a lot of chronic pain patients are just very anxious. Again, mood stabilizers, most people start antidepressants and stay on them forever. That was never the reason, the target of it. You're supposed to start them for a reason and then try and treat the underlying problem. It's normally, some cognitions that are depressive thinking, whatever, and then you then treat it with clinical psychology with the aim to come off mood stabilizers. So we're rattling on at pace, but I do apologize. This is the whole superficial thing. Let's just try and get through as much as we can. Who and when to refer? I mean, that's, again, I'm all about quality of life and function. I just think the sooner the better, to be perfectly honest. I think you're all intelligent people with a number of tools in your toolbox of how to manage pain. Basically, if you've done some sensible things and you're worried and it's not getting better and it's starting to get functional impairments, refer. This is the quality care statement below that I just sort of copied and pasted. That's the new thing that's come out just last year. It's got an awesome number of statements, which I'll show you. It's for an acute episode of lower back pain, but it's relevant to everything. Basically, if they're not getting better, just onwardly refer. The biggest worry I have is when I see people out of work. I need to play. So I'll try through these. Need to drink more non-alcoholic beverages. So they're off work for more than 3 months. The worldwide data is terrible for the likelihood of them getting back to work. So again, if someone's off work, not coping, just refer. Expectations. Again, someone told me this first statement a while ago, and I think it's awesome. And they kind of look at you and laugh, but it's true. Like we live in a society whereby you just expect to get a pill, a potion, an injection, or sulfuration just to get you back to what you were in your 20s. You can't. That just doesn't work. Pain is a normal part of life. The problem is if you're then overthinking it and other things are happening. Listen to the patient, try and work out if anything terrible is happening, but just be aware that there is somatic symptom disorders, which are a spectrum. People sometimes fulfill diagnostic criteria, sometimes they don't, but sometimes people are just getting more pain than what the underlying reasons for it are. And it's important just not to then chase it with injections and drugs and actually say that, there's nothing too much to worry about. Maybe we can do this and this just to try and facilitate, and then, just simple things really. But we can do a lot of damage. And I see that in my life as a pain specialist. I do lots of interventional injections, and people can have this roller coaster ride of, I worked for 3 months, but I'm back to square one again. So, well, or everything you do is maybe worse. It's like, well, that means I'm not doing anything else. Just start with the end of the side. Opioids, right. The next bit. So this is it's the kind of classification. So what we're going to talk about is classifications, but the side effects. I want to talk a little bit about the reason why everyone's so negative against them worldwide, because it just comes up as everyone talks about addiction, which is not the major issue. The terms now that are widespread use is typical, atypical. The typical are the old-fashioned ones, the morphines, the oxycodones, the fentanyls, things that just act on mu receptors. They're great. I mean, I used to be an anaesthetist, and there's nothing better for acute pain. But the problem is when you start having constant exposure, it then starts creating other problems, which I'll talk about in a minute. The atypicals is the term for these new ones, which are basically antidepressants with a little bit of opioid activity. Is how to look at them, really. They're good for acute and they're good for chronic pain, but you just got to, again, be careful, just not jumping straight into that. What's the problem? So acute, fine. I think the typical opioids, everyone knows about the acute things that opioids can do. Interesting, where in an area of anesthesia, for the last about 10 years, we've realized that actually opioids cause significant immunosuppression. So when people are having cancer surgery, we do our best to avoid giving lots of opioids because of all the other effects as well, but we do know it causes an immunoparesis, which therefore risks, distant seeding of the cancer that's normally mopped up by our immune system. Every single one of us in this room at the moment has cancer right now, including myself. The reason we don't develop full-blown cancer is because our immune system mops them up constantly. Opioids kind of knacker that. Chronic problems. This is where, so the first thing, tolerance to physiological dependence. So that's not really, in isolation, that's not really a problem. Tolerance, basically, you just keep giving more, it's fine. Physiological dependence, withdrawal symptoms, again, you just keep giving more and then never stop it. This should be fine. The psychological dependence, again, isn't really a big issue. Most pain patients are just in pain and are looking for someone to help them. Anyway, move on. The main problem is the pathogenesis, the disease-causing aspects of opioids, which I'll go on to next. So what is the pathogenesis? Well, a few things. So opioid-induced endocrinopathy, again, there's lots of articles of that, but basically the hypothalamic-pituitary adrenal axis as well as gonadal axis causes all those issues. Depression indirectly through usually the sex hormone depletion, and then indirectly you deplete your dopamine reserves. People on long-term opioids are depressed, and it gets worse, which then acts on everything else inside the brain. The pain experience gets worse. The opioid-induced hyperalgesia is a weird thing to think about, and again, I never really understood it until I did pain. It's a weird concept to get your head around, isn't it? But what happens is that effectively, morphine is a toxin. We have endogenous opioids, but morphine drugs are toxins. They don't just work on opioid receptors, they actually work on a lot of other receptors. Most of the lectures are about these toll-like 4 receptors, which are active throughout our immune system. Our glia is an umbrella term for the 90% of our nervous system that is non-neuronal tissue. So the glia basically are aggravated and activated by constant exposure to opioids, which causes, you can see, and I think I've got a video just to sort of indicate how active this part of our nervous system is. It's a conserved molecule for hundreds of thousands of years, and it's initially actually a bacterial lipopolysaccharide receptor. So hence, when you get a viral infection, you get bacterial infection, that all over body ache is neural inflammation with our nervous system, sensitization, more pain. So that's what you're doing to people with constant, not you, sorry, but that's what historically has happened with people starting on opioid drugs. You get a bit of improvement, tolerance to hyperalgesia then means, get more, and then you end up just stoking the fire. And in actual fact, you end up just treating withdrawal symptoms when you keep on the drugs. But you notice the declining function over the years. But anyway, I'll move on. But it's bad. There's a wee video here. I don't know if will it work? Can I stop it?
Protein.
Let me go back. So basically, this is Mark Hutchinson. He's a scientific legend or priest who does lots of experiments with rats and stuff. But this will last a minute. He basically got a mouse and they fire a laser into its skull. Watch this. Will it work?
A green fluorescent protein transgenic mouse, which has been bred specifically to have a thin skull occlusion, so that the authors in the manuscript could do 2-point photon electron microscopy through the skull. What you see here is the activity of microglia in real time, shooting up processing, sampling the microenvironment. What we have over here is a zoomed in portion of this showing this sampling of the microenvironment within the brain. It's estimated between about 20 to 25 minutes. Every 20 to 25 minutes, your brain is actually, all the nooks and crannies of your brain is sampled by microglia, actively surveying homeostatic brain. Microglia are also very responsive to damage. In this particular example, a laser beam is shot into the region of the brain. Again, using this animal model. What you can see is the rapid migration of microglia to the site of injury from a quite disparate region in a very rapid fashion.
Yeah, so that's how active the glia are in our nervous system. And that's what opioids kind of aggravate. Then we move on. So the atypical opioids. So these ones are better. Again, if you look at the literature, a lot of it's industry funded. Again, all you can say is it's much better than the typical opioids. It's not without its side effects. It doesn't worry me too much. A little oldie with some back pain that's not really responding to injections. Actually, the buprenorphine patch or a little bit of tapentadol helps them keep functioning. It's not really a worry. As long as you're using slow release preparations, I think the addiction potential, the abuse potential just to release it there. Tramadol immediate release is probably the only one that has a bit of addiction potential, but it's just less for everything. Not great, but less. And it is also defined for the treat both neuropathic and nociceptive pain. Just a quick, again, I'm probably going over time, but no idea how long we've been. 5 minutes. All right, quick, sorry. Tramadol, it's all right. I'll move on, so I don't think you need to know too much about this. I'll talk about the prescribing code then. So the prescribing code, there's 2 documents. really. One in 2016 and 2023, which is some amendments that are suggested at present. It's like they're quite easy to discuss together, they're quite easy to chew their way through. It's basically just described into categorized into prescriber medication and the patient-related factors. The recent adjustments are talking just about stimulants, script WA, and also thinking that actually the real-time prescription monitoring that might end up including gabapentinoids and benzos into that as well, but it's just a thought at the moment. This is the two boxes to really need to know. Basically, if people fall into the green box, you can prescribe, without any of those other issues, you can prescribe up to 90 milligrams of oral morphine equivalent, no more than 45 of that in immediate release form, without needing authority. This little app here from FPM, basically, if you just go into the App Store and type in opioid calculator, you'll this app comes up. It's quite useful for just working out what their oral opioid equivalence is. This is actually out of the document, but it's wrong. Don't look at any of this. The only thing is the yellow bit at the bottom. It's basically, I constantly get referrals saying I need authority for Tapentadol. You do not. Unless there's other issues happening that I don't know about, you are allowed to prescribe up to 500 milligrams of slow release Tapentadol daily without requiring authority. Types of pain, in 5 minutes. Nociceptive inflammatory. So this is a little infographic. This is the whole point of our nervous system. You've got activation of 3 receptors that send signals along our peripheral nerves up into our brain, our spinal cord, into our brain. Character, throbbing, aching. I'll get quick now, sorry, I just want to get to as much as possible. Neuropathic pain, so what's that? So basically there's a disease or a lesion causing damage to our somatosensory system. Nothing activating receptors, there's a disease, damage of the nerves, spinal cord, brain, and it causes this burning, shooting, sharp, dysesthesia type pains. Hence the character is really important. And then nociplastics, this is the term for where actually there's nothing wrong with the hardware anywhere. It's all a software problem. They can say anything. Usually it's a widespread ache or something like a flu that never goes away. But this is the one that's more difficult to treat. On to treatment options for the specific types of pain. So again, this is the clinical guideline for lower back pain. Again, it just talks about acute presentation of lower back, but I think it's actually quite relevant for everything. This is, don't read this, but this is the kind of the quality statement, but it just talks about, it's just sensible advice, which I'm sure you guys will do. Just do a good clinical assessment, try and figure out what's going on, do the psychosocial stuff. Don't scan everyone, be careful about drugs. And it's, you don't actually start talking about drugs until, 7, which is probably right, that's just reassurance. And this is quite normal, just use some simple, medications. And then basically ends, if it's not improving, just refer, it's not again, not helpful. This is another thing just to talk about. The common things for lower back pain is facet joint pain. So again, it's up here. It's these little facet joints at the back. It's superficial. They get overlying muscle spasms. It's normally tender. And it's worse when they bend back. You tell them to stand up straight, lock their knees, bend back. It's absorbed, and it's usually facet. Pain further down, this sort of direction again is usually sacroiliac related. Quite commonly, you get pain. People are pointing out over here over the top of their iliac crest. I mean, you show them the picture and say, look, that's what you're pressing. That's what I'm pressing on. There's nothing there. All there is the fluneal nerves that go over the pelvic brim, and it's usually a twisting injury. And that's quite simple to treat, but it's nothing harmful. As soon as they say, oh, it's just a bit of a muscular thing, you can relax and get on with other stuff. Treatment options for nociceptive simple analgesics, muscle relaxants, which are not benzodiazepines. I just use simple things like orphanedrine at a decent dose, magnesium spartate, maybe dantrolene, things like muscle benzodiazepines and baclofen. They can just create dependence and tolerance, and then consider atypicals. From the interventional point of view, again, this is a lot of my work. What I often do is, so patients get a sedation in theatre, and you end up starting off just with diagnostic injections. Usually it's widespread, and you have to do, I think sending someone to a radiologist and getting a single facet joint or something done, doesn't really make a huge impact. You often have to do a bit of a carpet bomb in the area of an SIJ, a fluneal, a few facet joints, a GTB on the side, and then they usually come back 3 months later. Everything's cured, but it's just this one little point, and then you can decide where you go from there. So this is just pictures of some cervical facet joint injections and SIJ injection. Beyond that, rhizotomies are common. Again, that's basically denervating a joint. This picture here is basically the nerve that supplies the facet joint, above and below. You could just place a needle there, and you hit the heat tip, and it coagulates the median branch. And that can help for, up to a year in a lot of people. But again, if they combine that with some movement therapies, reactivation of the muscles and the rest of it, hopefully you just don't have to keep doing it all the time. You can freeze it, you can burn it, you can pulse it, which is a kind of neuromodulation. Neuropathic pain, this is the guideline. So if you just Google WA Therapeutic Advisory Guidelines on neuropathic pain, the first thing that comes up is a PDF. This is just one of the sheets of 7. They're really good guide. It's 2017. It's a wee bit out of date, but it's a really good guideline on just actually how to treat neuropathic pain. Obviously, if there's an underlying cause for it, if it's a diabetic problem or whatever, just try and treat the underlying cause, because that's the biggest impact. But basically, neuropathic pain is making sure there's nothing pinching a nerve, there's no structural reason, treating the underlying disease, and then potentially drugs. And the drugs, they've got side effects. They're all just always start low. That's all I can say. People often start, freak out when it's far too high a dose, get horrible side effects, then it's I'm allergic to it, I can't take it. Just start really low and check it. Neuromodulation is probably the other thing for neuropathic pain. It works really well in selected individuals, but actually selecting that individual is the main thing. The conditions most commonly it's called failed back surgery syndrome, which is a bit of a crap surgeon. It's kind of insinuating, isn't it? But it's not. It's just you've done the surgery, but you've got ongoing nerve damage, so you've got ongoing radicular pain. So neuromodulation is awesome for that. You can put it in the neck, right? You can put it anywhere. The conditions usually are, again, back pain, CRPS, peripheral diabetic neuropathy, and post-operative neuralgia. There are lots of other indications, but those are the main ones. What is it? Well, basically, you place these little pads or leads within the spinal canal, behind the dorsal columns, and then you also have an implanted pulse generator, and the patient has remote control. It's a process of getting it all done. You have to have a trial. You run through multiple programs, of which there's billions of potential combinations. This is what it looks like an X-ray. And then Norsoplastic. Widespread pain people, so I'm being told to shut up. But however, education is the biggest thing you can do for people with widespread pain without a specific reason. So the norsoplastic pain, central sensitization, avoid giving them drugs that you know are aggravating it, treat underlying psychological problems, try and reassure them. The YouTube clip, there's a guy based in America, Professor Daniel Clough. He does these educational videos. It's an hour and 54 minutes long. If you just Google again, chronic pain, it's all in the head. I tell patients to look at it films, sit with their partners to look at it, because most patients look normal on the outside, specifically fibromyalgia patients, and they just need a bit of education for them and their family. That's the biggest thing you can probably do. Try and get the multi-disc sort of approach. Low dose naltrexone is the thing you might see coming out. It's a glial modulator. It basically does actually sort of change it works on Toll-like-4 receptors, but it's glial modulation. It's not actually causing morphine blocking, but you can see a huge response in some people. Everyone's a trial. It works in a decent amount of people. Memantine is another thing I've seen a huge amount of people benefit from. Cheap as chips, Alzheimer's medications, because it's got NMDA receptor activity, it can actually just desensitize things to the extent that they can actually come off their morphine drugs and then come out the other side of it, realizing its life is better. I think I probably won't be able to get onto this, but all I can say is cannabis. Everyone's prescribing it. I'm always just thinking what's in the patient's best interest. And the THC, as you can see, has got analgesic properties. CBD doesn't. It's got some other nice properties. So therefore, if people want to use CBD, it's fine. I don't care. But if you're taking THC, it's psychoactive. You can't drive. You can't work. A lot of the big companies are actually developing workplace documents of safety. And if you're on THC, you will not be able to work. So again, my goal in life is to make people a bit more functional and have a meaningful life. And that doesn't mean making them dysfunctional by not being able to drive or work. You might as well just have a bottle of vodka once a day. That's the same thing as if you're giving them THC. So it's a bit polarizing, isn't it? I just see the bad side of it, and it's expensive, and patients are just vulnerable, and they'll take it if they believe it. But is it an expensive placebo? I don't know. Most people just say they sleep better. I think there's better, cheaper, more evidence-based ways to get people sleeping better, to treat their anxiety and the rest of it. So that's it there. So basically, the THC just modulates the behavior of the CBD, hence you get that. All right, finish. Thanks.
One question.